Okay. All right. Hi, everyone. Such a pleasure to be live again for another Rheumatology 101. Now you know the drill. Instagram, and I'm ready. Okay, so there was a question last time about the link between arthritis and psoriasis. So I want to apologize already. I'm probably going to mispronounce psoriasis. It's really hard for me because it's just not where we put the accent in French. So psoriasis is how we say it in French, psoriasis. So every time you hear psoriasis, just remember it's my French accent. I apologize. Psoriasis. So we're going to talk about the link between psoriasis and arthritis. And then I think you will get out of this live knowing more and what's the link. Okay, so that was a question that came on the YouTube video, and I appreciate, as always, you guys asking questions. If you do not know me, and this is the first time you're going through a live, I'm Dr. Isabelle Amigues. I'm a double board certified in internal medicine and rheumatology. I've done rheumatology both in France, and I love it so much that when I came and moved to the US, I repeated my training and did it again in rheumatology because that's the best specialty. Okay, so little story. So when we have arthritis, so like, for example, an inflammatory arthritis, because that's really what we're going to talk about. When we have an inflammatory arthritis, the way us rheumatologists think is that we're always wondering what type of arthritis it is. So we are asking you when it's worse, what makes it better, where is it? And then we ask you other questions. And the last time we talked about, when we talked about ankylosing spondylitis, you remember I did say we always ask for other type of manifestation. So it's not just the joint. We're also wondering if you have skin involvement, if you have gastrointestinal involvement, and so on. And so basically, when there is an inflammatory arthritis and that we don't have any serologies that are positive, we are going to always wonder if it's either a seronegative rheumatoid arthritis or if it's psoriatic arthritis. And so let me go into a case that is pretty typical, I would say. It's not all the time, but it's pretty typical. So actually recently, because again, it is pretty common. Recently, I had a lady that came in to be evaluated for joint pain. And she had typical inflammatory arthritis, so worse in the morning, associated with morning stiffness. And in addition, it was improved with exercise, and she had some swelling of the joint. And so, this is what we call an inflammatory arthritis. And when you're thinking, okay, this is an inflammatory arthritis, then you're going to look at, is it symmetric or asymmetric? If it is symmetric, and it's involving what we call the MCP, so the knuckles, the first type of knuckle, the second knuckles, and it's not involving the last knuckles, then we're thinking, well, maybe this is rheumatoid arthritis. Of course, we do the blood work for rheumatoid arthritis, whether it's symmetric or asymmetric, right? But if it's symmetric, you're more thinking, okay, this is maybe rheumatoid arthritis, maybe this is Sjogren, maybe this is a mixed connective tissue disorder, and you're thinking like this, right? When it's asymmetric, so it's involving one joint here, one joint there, one other joint there, maybe it's involving the back, then you're thinking, could this be a spondyloarthropathy? And in the spondyloarthropathy, you're going to always look for all the different involvement that we talked about last time when we were talking about the ankylosing spondylitis. And one of them is the skin involvement, such as psoriasis. So when this patient came in, she had this typical inflammatory arthritis. And then when we looked at where she had the joint pain, turned out she had back pain. She had some joint pain of some of her knuckles. And then she also had pain in one knee, then one ankle, and then the other elbow, right? So very asymmetric. And although you're always going to, as a rheumatologist, you're always going to look for skin involvement and for lungs involvement, cardiology involvement. The truth is that this is even more what would be the word? Like it's gonna, sort of like get our antennas out for a spondyloarthropathy. And so that's exactly what happened with this patient. It's like, wow, this is asymmetric inflammatory arthritis. It's involving the back and it's involving the peripheral joint. Let's make sure there's no psoriasis, right? And so psoriasis is this skin condition that basically gives some patches, but it can be very small also, but patches that are very flaky. You very often we see it in the elbows, on the outside surface of the elbows, so not the inside, but the outside of the elbows. And you can also see it in the scalp. And so some people think that they have dandruff, but actually really what it is that it's a psoriasis. You can also have it in the ears. You can have it in the belly button and the crack of your butt, right? And so, of course, when you have it everywhere, when you have it in the nails, the nails, then it's pretty easy to make a diagnosis of psoriasis. But it's when it's hidden that's when our detective work comes in. And the truth is that this patient that had this asymmetric inflammatory arthritis involving the back and the peripheral joint, turns out she also had evidence of a rash that looked like psoriasis. And actually, it was typical location. So she had some on her scalp, she had some in her ears, on her belly button, and in the crack of her butt. And the truth is that she didn't actually know. She thought she had dandruff. She didn't really think, and she didn't, you don't necessarily look at your butt. And so she had not really paid attention to this because it was very little. When you have inflammatory arthritis and psoriasis, you can make a diagnosis of psoriatic arthritis, okay? So the link of psoriasis with arthritis is that if you have an inflammatory arthritis, the chances of you having psoriatic arthritis are actually pretty high if you have psoriasis, okay? And so that's where the detective work comes in. And that's, one of the things that I love about rheumatology is that it really helps you figure out what's going on by doing a really good clinical exam and really talking to your patient and listening to what they have to say, right? So it sounds easy and you're like, well, okay, so I have psoriasis, I have an inflammatory arthritis, boom, that's it, psoriatic arthritis. But there is a thing that makes it a little bit complicated, is that psoriasis is actually pretty common. So this skin involvement is actually pretty common. And there is one type of joint pain that's also very common. It's the osteoarthritis, which is the wear and tear of the joint. So as a rock climber, personally, I do have a little bit of osteoarthritis. And if you actually are a rock climber, you know that very often we have it in the bigger finger because that's the one that can, reach a hold. And so we are putting a lot of pressure on our hold. So I do have a little bit of osteoarthritis in that. So it's called the DIP. It's the distal interphalangeal, and it's very common. I've had this since I'm like 20, in my early 20s, because I was rock climbing at the time and I didn't know how to do it. So I was putting a lot of pressure and it's repetitive. So that causes osteoarthritis. With age, you have a chance of developing osteoarthritis. And the thing with osteoarthritis is that it can look like psoriatic arthritis. It can look like a reactive, like an inflammatory arthritis of the peripheral joint. And so when you have osteoarthritis and you have psoriasis, you're thinking sometimes that this is psoriatic arthritis, but it's not. And the thing that we have to remember is that, well, if you just have the psoriasis, so just the skin involvement, you don't necessarily need to give biologics. You don't necessarily need to give a ton of immunosuppression. You can just give some cream. And then also, like, for example, this patient, she wasn't really bothered by it. So you may not do anything at all, right? And so if you have osteoarthritis with psoriasis, and then suddenly you're like, okay, I'm going to make a diagnosis of psoriatic arthritis, but actually that is just osteoarthritis with psoriasis, you have to be careful because you may overtreat, right? And so that's the role of the rheumatologist. I'm just going to give you a couple of things that make us think, okay, this is more inflammatory arthritis, this is more osteoarthritis. So number one, if it's only the DIP, so the last joint of your fingers, and then there are some deformities that look like it could be like osteoarthritis type of deformities, then, and it's not inflammatory, so that the pain is worse when you're doing something, that you don't really have morning stiffness, then you're like, well, it looks more like osteoarthritis. You do x-rays and you can actually see some difference between osteoarthritis and psoriatic arthritis, okay? I think really when you're not sure, you want to actually really like make sure that you're doing the blood, like some blood work, seeing if there is any sort of inflammation, because there is inflammation, it's more likely to be inflammatory arthritis and psoriatic arthritis. You're going to also double check if there is any type of erosion on x-rays that are consistent with psoriatic arthritis. So there are some very specific signs on the x-ray that tells us, okay, this is probably psoriatic arthritis, okay? And so that is how we can make a diagnosis of psoriatic arthritis and differentiate it with psoriasis plus osteoarthritis, or the wear and tear, okay? So that is, the good news is that how do we finalize, how do we make this diagnosis basically at the end, is that it's really an association between the clinical symptom, the x-rays, and of course the blood work, because the blood work will help us figure out if you have rheumatoid arthritis or lupus or something other. And so that is, how we make a diagnosis. Okay, so there's definitely a link. Remember that in rheumatology, we're talking autoimmune and inflammatory issues, and that is basically affecting all of your body. That, yes, most of the time our patients come to us with joint pain, but that is just one of the symptoms. And you can, one of the other symptoms that are very common is the skin. And we are looking at the skin to see what's going on, basically. And that can give us a lot of clues, because there are some manifestations that are more common in some sort of different conditions of psoriasis or scleroderma, as we talked the last time, or lupus and so on. So we always have to be very careful and really look at the whole picture, and that's why you need time. Okay, so hopefully this has helped you. If you've watched this and you enjoyed it, please share it. We have the Rheumatology 101 live on YouTube. That's where they live, although I think I've started putting them on Instagram. I'm not the best on Instagram. I'm really sorry about this. I'm trying not to be the best, honestly, on social media, but I hope this is helpful to you guys. If you're watching this on a replay, put hashtag replay. And otherwise, I will see you next week. And then hi 2202, hi I'm Zaman, Nicole, hi Anderson Paz, hi. And then thank you so much for joining live. And then I'll see you next week. Take care. Bye-bye.